I get this question a lot. So in autism, we think of these impairments as presenting a lot of different ways. So as aggression, as autistic meltdowns, it can be a lot of different things. I see a lot of really strong, fast responses, and I don't even know, I'm angry until I'm really angry. We see aggression and self-injury as a form of emotion dysregulation. But again, there's different causes for that. It doesn't have to be a mental health issue necessarily. You can sometimes see more withdrawal, so less speaking, or kind of like almost a regression, a small regression in skills. So less able to do the things that they're usually able to do in their day-to-day lives, maybe less speech. You also can see a lot of different other presentations. So we see what, people a lot of times call a meltdown. You might see more irritable behavior, or other aggressive behavior, or anger. And you might see more kind of internalizing behavior, right? So seeming more anxious, or seeming like you're kind of sad or depressed. So it can really differ a lot. I guess is the way to think about this in a small, it really depends on the person that you're talking to and what it looks like for them. Common triggers to look for. So these are probably the same for anybody, whether they're autistic or have ADHD or not. Is being hungry or thirsty, noticing a difference in pain, a change in medication, a lot of times, or change in dosage of medication. Sometimes we'll see differences in dysregulation. Somebody that's tired out, it's the end of the day, or if they didn't sleep well. And then for those who start menstruating or having periods, as they get older, that's also something that can be a trigger a lot of times for a lot of dysregulation. In terms of things to notice or pay attention to for early signs of distress, so that might be coming towards a meltdown, or it might not. I see quite a bit of increase of repetitive behavior. So rocking, it might be a change in posture. So you see kind of a tensing up. For some people who pace, some people autistic people pace, and that's okay. Sometimes that's their way of thinking through things. When it comes to dysregulation or distress, think of it, as it seems more, it's not purposeful, but like trying to get them away from pacing in that time is a little bit more difficult. You might see someone who otherwise is able to answer you and kind of, be able to converse a little bit more, or answer questions about what's going on, not able to answer. It might be really hard to grab their attention, or harder than usual. And you might see some more hyperactive kind of behavior. So just really not able to sit still. Or really trying to get out of a situation. If it's a situation in which, they're starting to realize, oh, I'm distressed, and they're just trying to get out. One of the most important things to think about with this that I always bring up is that there is a difference between what a autistic person will call a meltdown, or some people call a meltdown, and what's a temper tantrum, right? So there's one really important thing to take away from this, is this kind of distinction. Temper tantrums, mostly kids, but adults are good at it too, is a behavior that you do to purposefully achieve a goal. So this is really frequent with kids, right? Like I said, adults, if we've seen the last couple of years, can definitely do this. But when you think about a kid, someone standing with their kid at the grocery store waiting to check out, and a kid starts crying, screaming about not being able to have a candy that's, at the register. That's kind of, they're screaming and crying in order to get what they want. A meltdown, on the other hand, meltdowns are not really meant to be, they're not manipulative. They're not a purposeful behavior that someone is trying to do to accomplish something. A lot of times we were recently doing an interview study with teenagers and adults, autistic adults and teenagers and their caregivers. They talked about this as something that is like wholly under their control, not under their control. It's a response to some sort of stress or something in the environment, like too much sensory stuff's going on and they're overwhelmed. And they can't get out of that behavior once it's started in place. So once a meltdown is fully underway, they've kind of described it to me like as I got to ride the wave and wait till it calms down a little bit and then I can do something. It's a little bit more difficult for them to like get out of that once it's started. We can talk about why this might be more likely to happen in autistic folks, but think about it as something that's like their ability to regulate those emotions that we're doing all the time every day kind of it's out of their capacity at that point. So this is kind of like the extreme version, an extreme response that we can kind of see. Okay, a couple do's and don'ts when I see meltdowns occurring. So I suggest not asking questions. And a lot of these are the same for everybody, whether you're autistic or not. Asking someone to calm down or just breathe. I don't know about you, but that really irritates me if I'm mad or upset. So something like that, I wouldn't suggest doing. I wouldn't ask a lot of questions to them at that moment when they're having a meltdown of like how they're feeling, what happened, you know, telling them how to behave in that situation is probably not helpful when you're already having a meltdown. And I wouldn't talk about punishment or consequences until much later. So something that our colleagues that work more in hospital settings and inpatient settings will say, where they're dealing with this kind of behavior really frequently sometimes, is that even after the meltdown, someone might look more calm, but that doesn't mean that they are fully calm. And they're still probably kind of at a heightened state for a few hours at least. And so doing punishments or consequences the second that someone stops crying or, you know, is throwing that kind of large scale meltdown is not going to help you. Okay. Do's during that time, I would say trying to be as calm and warm and neutral as you can. It's hard to do, but it's helpful in that situation. Thinking about the environment and the sensory stimuli that are around. I mean, when there's other people in the situation, like when I talk to teachers, you know, clearing as many people out of the space as you can, or at least from that side of the room. Excess things that can be thrown or used to hurt yourself or someone else, try to get those out of there. And then in terms of the sensory just environment that might be overwhelming, you know, if it's a place where there's really bright fluorescent lights, can you turn those off without being in the dark? If there's, you know, loud music playing, can you turn it off or get somebody into a situation where it's not as loud? If you have your fidget or sensory materials around and that's something that that person responds to, that also can be helpful to have in the situation. And then I would say, you know, eliminate as many demands or things that they have to do at that moment. I wouldn't ask someone to choose what they want to do next. I wouldn't ask, you know, them to describe what's going on. Because like I said, in a moment when they're already in a meltdown, it's really hard for people to usually express what's going on, even if they can in other times. And just try to sit quietly in, you know, close to the person or around the person so that, you know, you make sure you can monitor the situation and they know that there's somebody there if they do need someone. More do's, things that I think help, you know, when you're working with somebody or this is your kid, thinking about something that is encouraging for you to say can be really helpful. Using their name when you do talk to them and saying it's all right, it's okay to be upset, you know, we'll just kind of stay here and wait, I think can be helpful. When they do have to, when they're in the middle of something and it's a task maybe that was overwhelming and what might have created the meltdown, I would think about, you know, working together collaboratively and kind of saying like, how can you simplify it so that you can kind of get over it and then help with the situation and going forward so that, you know, you don't wait till they get calm enough and then introduce the same thing that upset them and then it goes back to being upset, you know. So something like, it's really hard, let's do this one step at a time, we'll do it together. And then, like I said, I think something that we really can see is that sometimes autistic folks may look calm, but they don't feel calm inside. So they may not always be able to express that to you either. So just proceeding kind of slowly after someone has had a meltdown. So one example of this that we got is that my colleagues and I get a lot of emails based on our work on this. And so this is one example from a mom who said, you know, my 9-year-old son has high functioning autism and extreme emotion dysregulation. You know, he's at once the most capable and the most disabled person we know. He can do all of these cool things like, you know, being a pitcher on the Little League team, being in the school musical, going to school itself is the struggle. In the second paragraph, she talks about, you know, his dysregulation manifests in severe emotional outbursts, verbal, physical. But when he's regulated, he's more rational, kind, and mature than his older neurotypical brothers, right? So emotion dysregulation, she said, is absolutely his chief obstacle to enjoying his full life, having the chance to enjoy his talents. So this is the kind of thing that we often can see, is that this is what is holding somebody back often, or getting in the way of them being able to do a lot of things that otherwise they can do, or making a lot of progress in other areas like school, in which otherwise they could do. Okay, so let's talk about emotion regulation problems specifically in autism and why they're at least a little bit about our knowledge that it is more common. Okay, so one major barrier that came up is that it's really hard to measure things and know that emotion regulation is more common when there's no proper measure or exactly right measure that you want to get at with the things you want to get at. When we think about this in mental health, a lot of times the measures that are out there are not developed for people who are autistic, and they're not always really appropriate. So an example I think about is if I'm working with somebody who is less verbal and doesn't use a lot of verbal speech to communicate, maybe they use some sort of augmentative device or they have a tablet with them, and sometimes they're able to speak, for example. That, like a measure for anxiety, for example, might talk about someone talking about their worries. Maybe that person isn't going to talk about their worries because they don't talk that much. Just as an example. So those measures aren't getting at things exactly the same way. And so when we think about this, they don't necessarily work as well with autistic people. So my colleague here and the lead of our REACT lab, Carla Mazowski, and some colleagues, great colleagues here in our department who have worked a lot on developing PROMIS measures, which are based in an NIH program, created a measure called the Emotion Dysregulation Inventory. So they use these PROMIS methods, which are developed to make really good, short, and effective kind of measures to measure things in a brief, succinct way and language that people get. So to do that measure, just as a really quick background, they used 3 really big samples to test out their items. They used an outpatient sample online, so caregivers of autistic kids from 6 to 17 years old, 1,300 of them, through an online registry. They used about 400 at the time from an inpatient collaborative group, research group, which is, you know, youth basically. So like as young as they'll take people in inpatient unit 4 to about 20 people that are autistic. And they included that inpatient sample to get at really severe forms of emotion dysregulation, right? So that's why they're in the hospital in the first place a lot of the time. And they used 1,000 US census matched caregivers of kiddos from 6 to 17. And so those were not autistic necessarily and meant to kind of match people based on age and race and ethnicity and socioeconomic status and all those things. So one of the really helpful things with PROMIS measures is that you are able to get a lot of feedback from the beginning to make sure measures make sense and measure what you're looking for. So you do what were called cognitive interviews. And this was bringing in caregivers and having them think about, like, what does dysregulation mean to them? What kind of things do they think of? How would they describe their own kids' behavior? And then when we had items, going through each item, having multiple parents and caregivers look at it and say, what does this item mean? How would you answer it? How would you define these things? And so that in a way makes it much better, because I've read a lot of measures that makes sense probably to psychologists and psychiatrists, but don't seem like they're written in a way that makes sense for normal humans, the rest of us in the world. So I think that probably would help. And so this is some of the items that we have on the EDI, and it's freely available on our lab's website. You just sign up and we give you access to the measure. The only reason they're asking for people to sign up first is just so that we can email you when we have like new norms or new shortened forms or things like that. So this measure ended up breaking out into 2 scales. So reactivity there on the left, we're talking about like, here's some of the items for the examples. We're talking about those strong emotional outbursts that are strong and quick and really big, and kind of happen sometimes without even knowing it's coming. Those kind of meltdown kind of behaviors too. So emotions going from 0 to 100 really fast is what we hear a lot. And it's also the kind of stickiness is what I call it of emotions. So emotions, like difficulty calming yourself down. So if you're feeling angry, it's like someone that then kind of feels angry for quite a few hours or the rest of the day, or even several days sometimes. And they kind of feel stuck in that emotion. So that's the reactivity side. The dysphoria side, we're talking about kind of more depressed, anxious, low positive mood kind of behavior. So it's more of like that internal, like withdrawn behaviors. So these are a couple examples of those items, like not seeming to enjoy anything, and that's different than usual. You know, not responsive to praise or good things happening, seeming uneasy. So those kind of things. What's also cool is that my colleagues here who are focused more on younger children have redone this whole process, you know, going through, picking items that make sense, testing them out with families, and have a young child version of the EDI that's now available and now published. And that's for ages 2 to 5. And what's really interesting is that it ended up giving us the same 2 subscales. So there's a reactivity subscale, those big, strong, out kind of external emotions, and that dysphoria subscale that's looking at the internal kind of withdrawing behavior. Okay, and then just a little more of a plug. We're working on a self-report version of our EDI right now. We're just about to start online data collection. So we did all of our items, you know, in our cognitive item development, we did our cognitive interviews, and now we're posting everything online. So that's age 11 through adults that we're hoping to see that, you know, emotion regulation inventory or dysregulation inventory will work well as a self-report, maybe with some differences in how we word the items. And we have a measure going called the REALS that is looking at adult, kind of like adult functioning levels, but I don't necessarily want to use the word functioning, but relationships, in the areas of relationships and employment and daily living, kind of living autonomously, those different things, and as well as life satisfaction. So that measure is also under development, and we're doing questionnaires, or online questionnaires right now for that. Okay, so we made the measure. Now we're able to measure emotion dysregulation. Surprise, when I was able to look at this data, from the development of the measure, and we had other measures alongside it, emotion dysregulation is more common in autistic youth compared to those without. So that community online sample, 4 times more likely to be really elevated in reactivity and twice as likely to be elevated, clinically speaking, like above a cutoff in dysregulation, in dysphoria. So we know that those things are definitely present. And the other thing I want to think about too is that this community sample, this online registry for autism, didn't require people to have mental health issues too. So this is just something that's really common across like the autistic community. We can kind of think about that as something that's important to know. And then in terms of what that's tied to in terms of outcomes, we know based on those studies, again, looking at this data that we had in this huge sample, you know, these 3 huge samples, that emotion regulation was tied to depression symptoms. It was linked to anxiety symptoms and aggression. So again, we know, just like in the neurotypical research that's been done before, that emotion regulation is tied to mental health issues, different mental health issues, and it kind of is transdiagnostic across them all. We also did a study looking at suicide items. So we had in a different measure some suicide related items, and emotion regulation, poor emotion regulation was linked to having more suicidal thoughts and more suicidal behaviors of self-injury, plans for suicide, things like that in youth. When we looked at other items that we had also asked, worse dysregulation was tied to kind of like those more intensive needs for psychiatric care, right? So more likely to be on psychiatric medications, more likely to have some sort of crisis evaluation. So having contact with the police because of extreme behaviors, going to the emergency room for behavioral issues. Or in some states, like in Pennsylvania, there's, in our county, we have like an in-home evaluation crisis kind of system. So you can call a number and people will come help do a crisis evaluation in the home first. Same thing. Those were all linked to higher dysregulation. And then also, which makes sense, more likely to be admitted to an inpatient unit if you have higher dysregulation. So kind of confirming a lot of what we suspected. Why this is happening and why we think this is a risk. So I think autism specifically, the characteristics or symptoms of autism are probably tied to some things that make dysregulation more likely. So think about rigid thinking styles, insistence on sameness. Think about sensory difficulties, so not getting enough sensory input or getting too much, like you're sensitive to loud noises or bright lights or too many people around, things like that. Another thing is difficulty with autism, with at least a subset of autistic people, they can have a really hard time with recognizing their own emotions. They can have a really hard time too with problem solving, so coming up with different solutions to a problem that comes up in their life. And so those different things are going on. And then obviously, I think there's probably some biological things going on. We know from research that autistic people, like their families, are also more likely to have mental health conditions, at least for some different genetic presentations. So there's something going on here too, probably, that is more genetic. That we don't have a full understanding of yet, but probably seems to be there, at least for some. All right, so let's move from emotion regulation, what it is, why it's an issue, to what I have been working on with colleagues about different ways that we can treat emotion dysregulation. Okay, so our program is focused on mindfulness, so I figured I'd do a really quick introduction to what that is. So mindfulness, got to switch my language now, is paying attention to those present moment sensations, thoughts, and emotions going on in ourselves without judgment. Okay. This started as a Buddhist tradition, obviously, and it has moved probably in the last 40 or so years, late 80s, early 90s, to being used for chronic pain, mental health issues, and a huge host of other things. Okay, so it's taking that concept originally and using it in a different way. So why we think this makes a lot of sense to use in autism, like I was just saying, we think part of the reason that dysregulation is happening is there's a decreased amount or decreased ability to notice your own emotional state, right? So noticing that you're getting upset before that meltdown happens, or noticing that you're starting to feel overwhelmed because things are too loud around you, but not noticing it before you have a meltdown. So we think that mindfulness would be really helpful here, is that you can increase that awareness, and also promote the ability to kind of stop and pause, slow down before you react all the time, decrease the tendency that we see a lot of times to avoid or push down those emotions, which is what I see a lot in my clients, and kind of work on that overall reactivity. So maybe being able to notice those things earlier makes it so that we can do something about it before it gets out of hand. So I wanted to do a really quick mindfulness practice. Helps me during the middle of my talk too. So let's do a mindful check-in. I won't worry about using my audio today. I'll just kind of verbally go through a check-in with you guys. So we're gonna do a quick 2-minute mindfulness. If you're comfortable and you're in a place that you can do this, please don't do this if you're driving. But if you're in a relaxing environment, or even if you're not, just try to kind of get yourself into a quieter space if you can, at your home or your office. You can either sit down, you can lay down, but if you're like me, you'll fall asleep. Or you can, even just stand still, that's okay too. You want to have a comfortable posture, so not slouched, but not, perfectly straight posture, unless that's how you usually sit or stand. And you can keep your eyes closed if you'd wish, or if you're more comfortable, focusing kind of just on a spot on the floor works pretty well, okay? So we'll take a few moments here, settle in, be still. And beginning our mindful check-in by bringing your attention to your breathing. So noticing your breathing wherever it might feel strongest to you. That might be noticing your belly moving up and down as you breathe in and out. That might be noticing the feeling of your chest rising and falling with each breath in and out. Or that might be noticing the air entering and exiting your nose. Just being present, noticing your breathing. And there's no need to change anything. You don't have to control your breathing. No need to constantly, count your breath or anything like that. And this might be the first time today in a busy morning that you've taken a break. Kind of just notice what you're doing and being able to take that break. And as you're beginning to notice your breathing, you might get distracted by other things, like noticing noise around you, noticing thoughts popping into your head of other stuff you have to do today. And that's okay. Just gently, when you notice those things, gently bringing your attention back to noticing your breath. And now, if you're ready, allowing your attention to expand a little bit away from your breathing. And now checking in and noticing any sensations in your body. Maybe some tension, could be some low level of pain or discomfort, or maybe you don't notice anything at all, and that's okay too. Just being present with any sensations you notice in your body. When you're ready, taking these last few moments here with your body and your breathing, noticing what's present, and checking in with yourself. And noticing a couple more breaths in and out. Okay. I'm going to try not to entirely wake anyone up who's fallen asleep, but we're going to move on to our next slide, okay? All right. So when we think about treating emotion regulation and autism, there's emerging evidence for this. So I just did this slide for completeness sake. It's a lot of text, but we have this across the age span right now. So we have a group study or a group treatment called STAMP that's for little guys 5 to 7 years old, that's teaching coping mechanisms for anxiety and anger. There's an individual therapy called the Secret Agent Society Operation Regulation. It's about 8 to 12-year-old is kind of their age range. And that's an individual therapy that works on treating emotion dysregulation and focuses on different coping strategies. So some mindfulness stuff is based in there, but a lot more that's cognitive behavioral therapy. Okay. Well, there's another study that, or another program that's been used with about the same age range, that kind of 8 to 12-year-old, kind of older elementary school, beginning middle school age. And that one is group-based, and parents and kids are in separate groups at the same time, that focuses on emotion regulation skills. So teaching the parents kind of how to handle that dysregulation when they're seeing it, and handling, group skills being taught for the autistic kids at the same time. There's the program I'm going to talk about today called EASE. Our initial trial we did with teenagers, so 12 to 17-year-olds, although now we've kind of bumped that up into early adults, so kind of like that 18 to 25-year-old range. We originally did ours with kids that did not have co-occurring intellectual disability, though I can talk about how we've changed that. And that's a mindfulness-based program, so just like that mindfulness I did, with other skills that we're teaching to kind of work on emotion regulation. There's a program I don't know a lot about, but it's school-based out of the UK that is working on emotion regulation in both autism and ADHD. There's dialectical behavior therapy, which is an evidence-based treatment that originally was used for severe suicidality and borderline personality disorder. It's been used in a lot of different other populations, but it's an adult therapy that is groups and individual, there's some trials that have been done now with those that are autistic adults, and it seems to work pretty well. So there's some small group studies that have been published so far in that, and some adaptations that have been done too, but generally DBT seems to work. What we need to stop happening as a field is something like this case that we had emailed to us or called to us. So an adult daughter who had a lot of emotion dysregulation and is autistic. No one seemed to know how to treat in their area. She said her daughter had been hospitalized many times, medicated a lot. Nothing seemed to be working well. And it didn't seem like a lot of folks in their area at least had familiarity with autistic patients. And so they looked around a lot. They tried getting her into existing DBT or cognitive behavioral therapy programs that were in their area. And the people there said, oh, we don't take autistic people. They don't accept people that have an autism diagnosis into their programs. Definitely a problem, because we know those things can work, just a little bit of adaptation. So I'll talk now about our EASE program and what it looks like, as well as some skills that could be helpful to you guys. So these are my co-developers. 3 of us there on the left are all at Pitt, at the University of Pittsburgh. Kelly Beck to my right there is a certified mindfulness coach for one of the types of mindfulness therapy that has been used the longest, MBSR. And then Susan White, who is actually my graduate advisor, is now at the University of Alabama. And she's been working with us on this too. So EASE, our idea was to create a 16-week individual therapy focused on adolescents and adults, and focused on improving that emotion regulation. So the capacity to be able to regulate your own emotions. We figured that using mindfulness skills would be really helpful, improving that overall awareness of your own emotional state. We wanted to teach different strategies as well to work on distress, like managing your distress, coping with it in the moment, and being able to get through it, and other other emotion regulation strategies. And we thought if that was improved and we can improve emotion regulation skills, we'd have a lot of good impacts on those downstream kind of things. So less problem behaviors, improving mental health diagnoses that are there, like depression and anxiety, being able to treat those, and hopefully, improving overall quality of life and functional skills every day. Okay, so I'll talk about the structure. Ours is an individual therapy at this point. So we meet with one teenager or young adult. We do have parent involvement though, and I'll talk about what that looks like. Our sessions are pretty consistent for most weeks. And I think kind of lends itself well for autistic people, but probably is helpful for anyone, is just to have a consistent idea of the schedule. They know what's coming. They can cross it off on the list that day when they're in there. And so we always do that mindful check-in, which is what I just did with you guys. We talk about whatever the new material is for the week. We talk about we do some other mindfulness practice that we're working on learning. So it can be mindful walking, it could be mindful breathing like we just did, or something else. And then we talk about what practice they're going to do that week and when they're going to do it. Another thing that we do is, well, most of our sessions have that kind of structure I just talked about, is we try to learn a concept and then have some sort of what we call a community session, which doesn't always have to be out in the community, but some sort of way to practice those skills in the situations that they're coming up in. So it can be, we've had all sorts of things. We can have, if it's being overwhelmed in a social situation or having something like that, maybe we go to Starbucks and order coffee. And that could be a situation that we practice, managing our emotions in a situation that could be stressful. It could be talking about an argument that the teenager recently had with their parent. Also, same thing. It can be anything like that. So we have all sorts of different things that can happen in terms of those community sessions, but they're kind of individualized to the person. And we have online content so that people can go back and review things and have access to the mindfulness meditations. They have audio and have them written out so they can kind of practice. I won't go over this slide, it's a lot. Basically, all I wanted to point out, develop this, we had a lot of different stakeholders review our manual. And at each stage, we've kind of revised a lot of things based on feedback. When we did our pilot study with teenagers, we also had feedback from all of the parents and all of the teenagers and all of the clinicians, and then kept doing feedback on this. So right now we're finishing up our trial that has 80 people across Pitt and Alabama sites that we're comparing ease to just general therapy and see if it works better. We also, during the pandemic, which was not planned, but ended up being during the pandemic, did a version of this for people with higher support needs that I'll talk about, called Ease Teams. And right now, as we're finishing up this big trial, is working on combining those two into one manual and hopefully getting it out into the community and training some community providers on how to do this. All right, in terms of who could benefit, just so that it's clear, the Ease Teams thing is just based on higher support needs. When we did our initial trial, though, we were looking at folks who had a nonverbal IQ above 50, but otherwise had intellectual disability as a diagnosis. So it was someone who had the ability of receptive language that could understand, some speech that's being told to them, but they didn't need to be verbal. If they had different ways of communicating or needed a tablet or something like that, we, make sure that that was available in the session. Okay. When we think about these two, this Ease versus E-Teams distinction, we kind of just thought about it in terms of different things that can be modified. So we think about caregiver involvement. For some of the teenagers and especially some of the young adults that we worked with, the parents were pretty minimally involved. Maybe they come in at the end or every couple weeks and they had contact with us. They were able to access all of the online materials, but maybe they weren't in the sessions. Versus for those with higher support needs, the parents are very involved. We had a couple initial sessions with the parents to get more information about what was going on and what kind of triggers and what kind of dysregulation we're looking at. So those differed a lot. We have some cognitive skills that we're teaching that changed pretty dramatically when we're talking about folks with co-occurring intellectual disability or higher support needs. We did less focus on that stuff, and I'll kind of show you the differences. There's more repetition for those that needed it versus some that didn't have cognitive difficulties and might have been able to learn the kind of material and move a little bit quicker. And then the use of scripts. So just like, key phrases that are helpful, and different language for, how to do a different practice. We used a lot more scripts and terms that were repetitive for those with higher support needs. So that was a little bit easier for them to remember. Oh yeah, when I'm upset, I do this. And then that was kind of like a little bit easier for them to learn the material that we needed for them. So one thing that we think is a little bit different and that we are proud of with EASE is that we think that we're kind of teaching some self-compassion and ability to tolerate distress more than some other therapies. So this is an illustration from one of our teenage clients, really good illustrator. And so she kind of got at the point of this theory that we've talked about quite a lot, which is I've learned the emotions are part of me and I can't avoid them. Like we're teaching that all emotions are okay. And this quote here is from an autistic mom who had an autistic child in our trial. And she really appreciated that we were working on understanding the cause of where this behavior comes, and understanding how to soothe and kind of, what are those coping skills that we can use in this situation. So we're, to her, it meant that we were making her kid have a better quality of life rather than focusing on how we're going to change the autism in that person. So how we're doing this, we're teaching awareness is the key thing. So we teach, just like a lot of other therapies, noticing the different kind of emotions that we have. We focus, what we say here is dimensional. So I focus more on the intensity of the emotion rather than whether you're angry versus upset versus anxious versus sad. So we really kind of focus on more generally like positive emotions, like if you're happy or excited, and we focus on those negative emotions, like all of those other ones I just mentioned, and we think about it more of the gradient. So we usually use these thermometers here. Our illustrator did these based on her interest in turtles. So hers were anxiety turtles here. And if she was fully really anxious or really in an anxiety provoking situation, she was a turtle and hid. And really, this is just about finding consistent language. For those that needed higher support or have a harder time, this might just be as simple as like, I feel good, I feel bad, and that's okay. But as long as we all have the same language, so the parent, us as the clinician, and the participant or the client have the same language is always helpful. And that way you can kind of always be able to communicate that clearly. So in terms of how you can do this anywhere without our treatment, help the person that you're working with notice their emotions. So simple system, it can be red, yellow, green. We've had a lot of folks do that. I was probably taught to them when they were younger and it kind of stuck. We usually can base these things on their interests to make it more fun and not as horrible to talk about emotions. And we usually really, as ourselves and as the parent, really talk about modeling this. So if you're feeling upset and your kids around you saying like, I notice I'm getting upset, I'm starting to get really tense and I'm starting to talk louder, I'm at a 7, I'm gonna go breathe. Something like that, to be able to teach them and show them what this is gonna look like. And then obviously things like understanding what the environment might be that causes this behavior a lot of the times, and noticing those things too. So, you want to be able to modify those things when you can. Not that we're teaching someone that they always can get away from sensory things that they don't like, but that you can, in some situations, have a safe space to go kind of be able to sit and take a break, things like that. Once we do mindfulness or use mindfulness to work on awareness, then we focus on using it potentially also as a calming strategy, or just something to do over time that could kind of help in the long run to keep ourselves a little bit more calm. When I talk to people in person, the most common question I get is, how are you doing mindfulness with autistic people? I would say, here are some of the things that we've wrote in this paper that Kelly really excellently pointed out. So we limit our metaphors. I mean, if you've heard other mindfulness audios before, you probably heard all sorts of like, imagine yourself floating on a river. We don't do all of that. It's a lot more direct. Here's what I want you to do. We tend to do longer meditations, so not like the one I did today for shortness, but give people more time to notice their emotion, their thoughts wandering or fidgeting. It's kind of paradoxical in a way. You wouldn't think that somebody has ADHD and is fidgety would do well with longer, but sometimes that is really helpful for them to notice those things. Permissive language, that's the kind of ing on the end of words. So noticing when you're ready, trying this, things like that. We probably do a lot more repetition when we're teaching mindfulness, and we practice the same mindfulness practices pretty frequently. And we practice it when it comes up in the session too. So if they're talking about something and start to get like worked up, and it's a time where we think that mindfulness might be helpful, we sweep in and do maybe a quick practice or an informal practice that I could talk about. Oh, and then also using physical aids. So putting your hand on your chest or your belly, or putting a stuffed animal on it to notice the rise and fall of your breath. Sometimes physical aids, like we have those stretchy Hoberman balls, that picture right here. That also we find really helpful. Like, can kind of picture their breath going in and out. Okay. I don't know if I have examples, time for both examples. So I'm going to skip this one, but this is an example of a practice called the body scan. You kind of focus on each part of your body one by one. And that's Kelly there with one of her clients. Oops. Hey, it went without me. Cool. Okay, I'm going to skip past it just for time, but give you an idea. Common struggles that we see is a hard time noticing these things, and that's okay. We tell people it's okay not to notice, and we focus on external things at first, if that's the case. So, if you have a stuffed animal, like a Pikachu, we have you hold it and kind of notice that feeling while you're sitting there holding it. Or external things like our therapy room has a really loud air conditioning unit. Noticing that kicking on and off. And then eventually I think it really helps then to like start to notice your internal things if you can start noticing what's external going on. We do some really short informal mindfulness practices, and this is to temporarily kind of focus your attention elsewhere when you're in a stressful situation. It can be using, like a stress ball. We have a lot of brains though, ours are. In our lab. So, squeezing something like that, or just even squeezing your hands together, focusing on the feeling of your feet on the ground, things like that. And I'm going to skip over this one too, but this was just an example of kind of using one of these stress balls to focus in the moment on what that looks like. In terms of having or focusing on thoughts, we teach some strategies to manage thoughts, especially ones that tend to make us upset. One, for any kind of level of support needs, we focus on helper thoughts. So if there's a tough thought or a situation, or what comes out is a kid saying I'm stupid, we think of a thought that kind of counteracts that a little bit. Like, it's okay to mess up. Again, our illustrator here had her own, remember that she's learning at her own pace, and she had this on her binder that she took to school. There's also cognitive thoughts or other cognitive strategies that we use for those that are able. So one is called diffusion, which we call distancing just to make it easier. That's out of acceptance and commitment therapy. And it's just like separating yourself from your thoughts, saying, a thought's just a thought. It doesn't mean it's true. And so this case, if it's no one likes me, I'm noticing that I'm having this thought that nobody likes me, kind of separate yourself out. Another is using reappraisal, which is used quite a bit by a lot of therapists. So, how can you reframe that thought? Is it 100% true? Why do you think that? And then just being able to reframe that in a different way. Okay, so far so good. We found that, we have data on our original trial, and we do have some preliminary data I wasn't going to bore you guys with. It looks like we're doing pretty good at reducing some emotion regulation and distress in people. When we found that, this is able to help folks get through more things in their life. And so we've had some interesting feedback from parents who were involved saying, it's really helped to have a common language and a common system so that both parents and everybody else that they work with, were doing the same thing. We said, that also have seen kids be able to report on that themselves too, which I think is really cool. All right, really quick, I will talk about future directions. So I think going forward with our research, we really need to understand why people are feeling this dysregulated. What things can we notice, if we're not noticing it in facial expressions or in their body? Is there something else that we can be noticing? And understanding like where this is originating. Another thing, obviously, for us is to get this into the community, these kind of practices, and train clinicians. And a thing for me that I'm really interested in is how does your level of emotional awareness or your insight into your own emotions change? How people end up doing in these kind of therapies, and how it contributes to emotion dysregulation too. And then another thing I'm very interested in is identifying and treating that risk for suicide. So, I always, when I talk to people that are working with kids and teenagers, I always want to point out that we know in autism that services really drop off when they reach adulthood. We're always making sure that we have good, better and sufficient services for kids, for autistic kids, but it really drops off in a lot of cases for adults. And I think we need to work with our mental health system to make sure that, those people are not getting lost. And that if they need mental health care, that they have access to it. And you can't just turn someone away because they're autistic. It would be nice. Okay. So along those lines, my new focus is we are really excited at Pitt that we got a large NIH grant, a center grant, to focus on mental health in autistic adults. I'm not going to bore you with all the details. I'm just going to say that our main question here is what contributes to mental health in autistic adults. And we're working on developing some more measures, including one of suicide risk for autistic people. We're going to do some really cool studies looking at physiology and cell phone data from day-to-day life. And we're also going to do some, our usual neurocircuits and look at things like neuroimaging. Okay, all of this resource information, I will make sure that I leave or make available to everybody if you guys are interested in it. We just have a couple like recommendations for resources for things like mindfulness practices, and hopefully one day ours will be out there too. Just some more things, our lab info is there. And then these are a breakdown of some things from a paper that we wrote based kind of geared towards clinicians about how to target emotion regulation with your autistic clients. Okay. But at this point, I will stop talking because I'm probably overran my time, and say thank you guys for listening and ask if there's any questions.
Yes, you did perfect on time. Actually, you were ahead of time.
Okay, I talk faster, always talk faster than I think, so.
No, right? We all do. So thank you so much for presenting. I do have a couple of questions.
Sure.
And then if anyone else wants to add any questions, they can go ahead and click on the bottom of their screen. And they should be able to type in questions that we'll be able to see. So it should say Q&A at the bottom there, and you should be able to type in any questions that you do have.
Yes.
But I'm going to go ahead and get started with the ones I have so far. Okay, so one of them is that, so my child has a really hard time telling the difference between a 7 and a 10. I think they're referring to that slide where you talked about that, are you a 7 or are you a 10? Because everything feels like a 10. And then if I try to negotiate and say, well, if it was a 10, this would be happening, then it starts to feel very invalidating to my child. Do you have any tips or tricks to how to teach the differences between, like, I know what's a 0 and what's a 10, but kind of those more nuanced differences?
Yeah, it's a hard one, and we come across this frequently, so you're not alone. I think sometimes too, even, I mean, I don't know how old your child is, but some of our teenagers just don't admit that they're out of 10. And that's okay. Like I don't fight with them on it. I'm like, that's fine. But then maybe the rule for a 7 is that we do things pretty similar to how we do it when it's a 10, like in terms of how we're going to manage that time, when we teach this stuff initially, I'd say we focus a lot on knowing what's in the middle. So we want at least 3 levels so
Mhm.
that we can understand like, low, calm, a medium level, and then a high. So if they can do that, that's fine. You can feel free to shift to that, or I would just say when I'm doing, when you're at a 7, like, what do you need? And we talk about this when they're calm too, which is, I think, really helpful. So like, what kind of stuff do you notice when you're at a 7 versus a 10? And some folks, I feel like some will eventually get around to noticing like the small divisions between a 7 and a 10, and some don't. And in that case, like my what I would tend towards as a clinician is say that we're going to treat 7 to 10 like it's the same thing in terms of how we respond to it.
Switching to, so kind of, I guess it sounds like 2 things. One, switching to maybe more of like a 7 through a 10 is kind of the same. So like low, medium, or high. But then also just not fighting that individual on, like if they think it's a 10, it's a 10, and then we're going to treat 7 through 10 the same anyways.
Yeah, I would just think about it like, what are you guys doing when it's a 7 versus a 10? And is there anything different that would help them,
Okay.
or do we just treat it the same? And that's how they do it.
Very, very helpful. And then one question was around permissive language. I think that's really important to think about, especially when we think about individuals with a diagnosis of autism spectrum disorder, potentially, that like when you're ready, or even thinking about metaphors might be a little bit more challenging to really resonate with.
Yeah.
So, it sounds like permissive language really resonated with this person. And then they asked for alternatives. So would that look like more concrete language? Could you maybe give a couple of examples of what that is?
Sure. I think, I wish I could bring Kelly in, but I'm going to channel Kelly as someone, that's like certified to teach and to coach mindfulness. I think when we're focused on permissive language, it's in the moment of the mindfulness. We have pretty clear-cut rules and standards before the mindfulness to understand like the expectations of it. Right. So like, you're not gonna say like, when you're ready, we're gonna sit down and start the mindfulness. It's like, no, we're gonna start the mindfulness now. And we know when we start our mindfulness, we're gonna try to sit still. Well, we don't have to sit still, but you're gonna sit in your seat. Right. And we're gonna do this. When we've been doing virtual sessions now, it's like also you're going to have your camera on. Right. And we're going to go to a part of the house that isn't as loud, right, so that you can practice this. So I think that's part of it too, is like mindfulness time is separate and we're gonna use that language then. Another thing that I didn't really touch on is part of that when we're doing mindfulness, and the reason that permissive language is used is because you're modeling mindfulness as the person like sitting alongside them or as the person teaching it. So you want to make it sound like that there is not a right or wrong way to do it. There's not a right or wrong way to notice things. It's okay if you don't notice anything too. So that part of it is really specific to that. I wouldn't say I do the rest of my therapy entirely in permissive language. You definitely would catch me not using it. The other thing with metaphors is we just totally do not use them. So I know there's lots and lots of online, like, we can all pull up an app on our phone for free that uses mindfulness. If they're doing a lot of metaphors, like imagine you're this, or imagine you're here, like I don't really use those. I have had families where using those kind of ones that, imagine you're in a calm place, like that works for them. And that's okay. It's just not what we usually are teaching because we want to use something that's more concrete. Right. Like, exactly. We're noticing our breath. We're noticing how it feels when we're moving or walking. We're noticing what's in our body. And that's kind of what we focus on.
Okay. That's very helpful. All right. We have another question. I have a 4-year-old, so a bit younger, and we are struggling with meltdowns. One of the triggers are due to things being moved in her room or touched. How do we deal when she is out of control and explain her feelings to her? We cannot reason with her.
Nice. Okay, that's a good one. So I'm going to assume that it's anything being moved. And even if you tell her ahead of time, it's really hard. I'm wondering if, because this kind of goes back to, for autistic folks, like a need for things to be in the same place or a need for things to be the same. If they're working on that changing over time,
Mhm.
maybe one of the options is you give them the option of which thing gets moved.
Mhm.
I find that to be kind of helpful sometimes.
Mhm.
I would also probably think about like when the things are not being moved and they're calm about it, like talking it out with them. Like, what about it
Mhm.
specifically? Like, which specific thing that gets
Mhm.
moved is what is making them upset? Because
Mhm.
then there might be other ways that you can manage it, like
Mhm.
I think of my aunt actually was diagnosed as autistic as an adult, and my brother is on the spectrum.
Mhm.
And she had a tendency to call my mom when she was having autism specific issues. So
Yeah.
one thing was like she bought new living room furniture
Mhm.
and she wanted the furniture, she bought it for her house.
Mhm.
It was still like the smell, the fact that it was different. She had already put it in like the same spot. The couch was where the couch was, the chair was where the chair was. She still couldn't handle it. My mom's suggestion was like, put a sheet over it.
Mhm.
Like put some bed sheets and some blankets over it for a few weeks until you like get used to the smell and then work on taking the sheets off, one by one. So sometimes with autistic folks, you just have to think about like prevention of the meltdown more so than what's happening during the meltdown itself. Because especially at 4, like I expect 4-year-olds to have like meltdowns
Mhm.
to some degree. Obviously, you don't want them hurting themselves or anyone else.
Mhm.
But I would start with the behavioral ahead of time strategies and then move from there.
Mhm. So maybe kind of chunking it down into smaller steps and letting the 4-year-old have a little bit of control over what we try first.
Yeah. And maybe moving it a little bit without moving it out of the room,
Mhm. Mhm. Okay, that's really helpful. All right, and then we do have some questions about the program that you were describing, EASE. And so it looks like parents would like to know what types of credentials will the providers of the program be required to have? So in order to implement it, would it be, a psychologist, social worker? Who would kind of be implementing this program, and how much knowledge would they have about autism spectrum disorder?
So if you want to come into our research meetings about ease, you're more than welcome because this is a question we're still working on ourselves. So right now we're starting to work on master's level and doctoral level folks that have autism experience and training them in this. So we have a couple different issues. So one is teaching the autism specific part of this. One is teaching the mindfulness specific part because the people that know autism don't usually know mindfulness. And the people that know mental health don't usually know autism, right? So I think right now we're thinking of having training materials that are available for those that are not autism providers, like specifically, or like your guys' clinic, like, right? So that is a specific place where you guys you're going to see someone who is a specialist in autism and neurodevelopmental conditions versus, back in the rest of the world, we're siloed out into these little things and there's autism providers and there's non-autism providers. Is teaching those non-autism providers a little bit more about autism while also training them in the mindfulness and the ease part of specific ease intervention. It's gonna be fun.
Well, as soon as you said, if you'd like to join our meetings, we had lots of people who would like to join the meeting. So
maybe what we need is so specific. I would love to have more families reach out. So feel free to email me. Like it will be really helpful. Honestly, to have more opinions from parents and from other clinicians of where we need to go with the training. We're trying to make sure that it's not an overwhelming amount of training, but as Callie especially, and the rest of us have learned, training in mindfulness when that's not that wasn't my main practice either, or what I was trained in. I was trained in CBT. It's a journey, right? Like to learn how to do it, and do it well, and plus then have to modify it and make sure it's appropriate for our clients.
That makes sense. So Caitlin's or Dr. Connor's email address is right up there on the screen. Connor CM2. So if you are interested in giving a feedback as parents, we know how important that really is. Feel free to shoot her an email.
Yeah.
Another thing that's coming up seems to be sort of in the same category of maybe generalizing. So there's two pieces here. One is that I think as caregivers, our kids are in school and then they might have therapies after school. And so, we have the opportunity to be with them some of the time, but they're with a lot of other providers and individuals throughout their day. Is there a way that you have found success in sort of figuring out how to generalize these skills to the school setting, or other therapeutic practices? So maybe collaborating with ABA or speech therapy, or anything in that sort of generalizing area?
Yeah, great question. We've had varying success with this, and it's really depended on, well, the receptiveness of the school or like the speech therapist or ABA therapist you're working with. By and large, I found the therapists are much more likely to go with it. Schools, yes or no. Just depends. Families have been great about this, and we've tried to help them as much as possible. So we kind of made a core, like once we've done a few weeks, we have made kind of a core information summary based on each kid of like, here's their lingo, here's what their emotion scale looks like. And I've, provided that to the family or gone directly to the teacher, whatever they prefer, and talked to them about like, this is what we're doing, this is what we're working on, and this is how, if you guys want to help do the same thing, or if I'm working with the younger kiddo, I would say, for their main teacher saying, here's their emotion scale, like, do you want to use this at all? So that he can, he or she can indicate to you before they're getting really upset, like, hey, I need a break. And can we think about what that looks like? So a lot of times it's just working directly with the teachers, with the other therapists, and with the parents all together. Because I find that can be the most helpful. But like having like a really quick summary of like, here's what we've been working, and some of the parents honestly like started doing it before we even got to it in the sessions of like, here's what we're learning, here's this. And we do also give parents summaries after each session of like, here's what we were covering. And so sometimes they've shared those with other therapists and with the school, to kind of understand like, here's what they're learning these kind of mindfulness practices. Today we talked about helper thoughts, or helpful things we can tell ourselves when we're feeling like upset, or today we learned how to be aware of what our emotions are inside, and here's what my feeling scale is. So I think it really depends on the school, but I like the idea of having it quick, having it, directive of like, here's what they're learning, like basically, and then here's what specifically we could do in the school. And I find for most therapists in most schools, if emotion regulation is an issue there, then they're willing to work with us on it because it helps them too.
That's really helpful. Okay. And then we also have a question around, so sometimes, what the recommendation so a lot of what you're describing is really skill-based, right? Like we need to be able to know how to use these skills in the moment, especially when we are more elevated or escalated, because it's going to be really hard to remember or to access that like logical side of our brain. So what's your advice on practicing these skills each day? I think a big thing that has come up is that should we be, putting this as part of our routine? Should it be something that we are rewarding children for practicing? What are kind of your general thoughts on practicing each day and tying it to a reward system or not tying it to a reward system? What do you think?
Those are both really good. You guys have been sitting in on our, well, not literally, but you guys have been sitting in on our supervision, haven't you? Like as we meet as clinicians. So generalizing is a huge thing. And I don't need to tell you guys that, right? So we know for autistic folks, generalizing what they've learned in a 1-hour session with me in a therapy room is not always going to like, go out to the rest of their lives. And it is especially hard, right, when you are already escalated. I think what we've learned is if we can catch people before they, if they go 0 to 60 and they don't realize it until they're out of 60, there's still a moment when we could probably intervene if they're able to notice it. So that's one part of this, is that we're focused on teaching them what it looks like before they get to the 10 or before they get all the way to a meltdown. So that's one part. Mindfulness can be used in that, in the early parts of that moment, but it's probably not going to be as helpful when you're having a full meltdown. And then the other part that you guys brought up is like, practice, right? So that is totally needed. We have learned that mindfulness works best when you've practiced it quite a bit. The traditional like adult MBSR way of looking at this is like they have hour practices, or at least 45 minutes a day. And that's really long. I don't have the attention span. I try, but really difficult. But what I would say for our kids is we're like, when exactly are you going to practice? We have a lot who practice like in their bedtime routine and build it in there. We have some kids who practice when they get home from school because they've had enough at school. Like, they get home from school and they usually are just like, because, they've held in and held it together all day. And so they've learned this is what I'm going to practice. And yeah, it's a really key for the parents to work with us and with our clients to like make sure they're practicing it consistently. I mean, I don't want to make it another like piece of homework, but unfortunately it kind of is. Like, it's going to be something that they've got to do. And practicing when you're calm is the biggest thing. If you are only going to practice, you're trying to be mindful when you're already getting upset, it's going to be really hard. So we found that like practicing just when you're calm and having, nothing else is going on, you're in your house, it's nice and quiet, or, you could find a quieter space in your house, like that's what they need. And I think to one of the folks I worked with, his dad was particularly insightful with this, is like, we should have practiced more before he started getting upset, so that it's not tied. The mindfulness is not tied to when he's upset. Because yeah, otherwise it's going to make it something icky. You guys had one other point and I'm already missing it. Oh, rewards. Yeah, that was it. So with rewards, I mean, we've had families where it is part of like, doing these things or going to sessions. We've had quite a few people that go out to eat after every session. And that's kind of the kids' reward, because it's not always the most fun thing as a teenager to go to therapy. I think practicing at home and not being tied to, part of all of your good behavior gets towards this amount of time playing video games or whatever reward is, something that's rewarding to them, I think is fair. Again, I don't want to make it negative. So I don't want to punish anybody if they don't do it. I always kind of say that to parents, but like we do want to like encourage adopting a new thing. And we all know like adopting a new habit, even if it's something we know we should do, is not easy. Yeah. Talk to me about trying to exercise every day.
Right. That is so true. And can you describe a little bit more about what that parent portion looks like? It sounds like they're really involved in these sessions, or at least in the debriefs of the sessions. Do they ever join you? Do they have their own skills that they're practicing? What does that aspect look like?
So that's a good question. I could have made that more clear. And part of the reason I didn't was we're still working on how we're going to merge these two manuals. So one is our normal manual. So kind of like traditional IQ level, cognitive functioning level. We usually had parents involved towards the end of the session. They'd come in for the mindfulness part, and they would come in for how we're going to talk about what they're practicing during the week. The kid would or teenager would review a little bit of what we're talking about, but like I said, we gave everybody a handout so that the parents were able to see during the session. And our stuff is all online, like those summaries and what we're practicing, so they could also look at it. If they had a tablet, we have iPads in our office and we can just kind of have them look at it. So they kind of know what's going on. Times when that's changed, some teenagers really didn't want their parents in the session, so we've had more minimal contact, or I talk to them via email or by phone in between sessions or right before the session. Sometimes for anybody, we usually brought the parents in at least for one full session near the beginning to talk about goals and overall to talk about like what the program's going to look like. And then for those with higher support needs and ease teams, our trial there was a little different. So the first two sessions were caregiver only. And we did a lot of that overall, like overview, this is what we're going to learn, this is how we're going to learn it. We got a lot of information from them because you guys are the experts on your kid. So like, how do they communicate best? What happens when they're dysregulated? What does that look like? What have you guys already tried? All of that information in those first 2 sessions. And in those cases, the parents were usually in the whole session with us. And they were learning mindfulness with us, and they were helping think about practice and talk about what had happened the previous week. The other thing that really comes up a lot, and this is regardless of functioning, IQ or verbal level or anything, is like, what happened last week? Nothing. And then we find out like they got kicked out of school for a fight or a meltdown where they were throwing things at people. And it's like, you didn't tell us. So sometimes talking to the parents in between sessions is really needed too, so that we know what's going on. But yeah, the parents generally have almost across the board been involved in learning the mindfulness with them, which I think is really helpful. If you're going to learn a skill and generalize it out, I can't come home with you guys. So you guys kind of have to help with that. And making sure they know what it looks like and are able to help them practice. And then making sure that they also know what's going to happen this week. And we talk about exactly when you're going to practice this thing.
Right.
Yeah.
That's very helpful. All right. Well, I think those are all of the questions. We really appreciate your time today. So for our audience, the next sessions will be on behavioral approaches to improving sleep or language development throughout childhood and adolescence. And then if you do want to earn a CEU, I'm going to launch that poll right now. So it should be on your screen that you can see.